Good afternoon and welcome, everyone. It's my pleasure to welcome you to the Fairbanks Ethics Lecture Series. We started this series in 2005 and offer about 8 or 9 sessions, some in combination with the Respect Center and others across campus, about once a month during the academic year. My name is Paul Helft. I direct the Fairbanks Center for Medical Ethics, and it's my great pleasure to welcome you. I want to give thanks to Amy Chamness, our program coordinator, who's been coordinating and organizing and doing all of the heavy lifting in this ethics lecture series for several years now. It really couldn't happen in the way it does without her. The lecture we've been doing remote site broadcasting for the past few years. So I wanted to welcome folks from the Riley Rock Auditorium, from IU Health North, West, Arnett, and Ball Memorial Hospital. And just a reminder, if you wouldn't mind silencing your pagers, electronic devices, PDAs, etc. I'm really looking forward to this lecture because, as any of you familiar with this area know, that this is a problem with more questions than answers. This is an incredibly difficult problem that we face. We are not a border state, and yet we are affected by it. You can imagine what's happening in the border states where this is a chronic daily problem. And we're really pleased to welcome Dr. Brian Decker here to give this lecture. And he hopes to make this an interactive session, so I hope all of you will not sit on your hands. So Brian joined the nephrology faculty in 2007 here after completing his fellowship here. His primary clinical and research interests are in clinical pharmacology of medications and the clinical implementation of personalized medicine in patients with chronic and end-stage renal disease, and he is the Clinical Research Center Phase 1 Principal Investigator. So in this capacity, he oversees the Phase 1 drug studies that are conducted at the Indiana Clinical and Translational Science Institute Clinical Research Center. He's also a member of the Eskenazi Hospital Ethics Committee. So in his role as an educator, he provides seminars and conferences to clinicians at the intersection of internal medicine, nephrology, and personalized medicine. And I just heard Brian introduce himself as a non-ethicist, and we love to have non-ethicists here because they always know a lot more about ethics than they claim to know. So thanks a lot for coming, Brian.
All right, well, thank you very much, and it is great to be here. As you know, this was a reschedule, the winter, and my bad acute bronchitis, I was glad we were able to get it in May. But today, I'm going to talk about the challenges to providing hemodialysis for the undocumented patient, and these are not the medical challenges, per se, which are formidable. This is more the landscape of the ethical issues that are involved. And so let's go ahead and get started here, because I only have an hour, right? How long do we have this room? An hour? Okay. All right, objectives. I think you probably have already seen these, the 3 major pieces of legislation that have impacted the health care of undocumented patients, what an emergency medical condition is as defined by the federal government, the indications for providing hemodialysis for most undocumented patients in the United States, and the 3 major sources of health care funding for undocumented patients in the United States. So to do all that, and again, these are more the nuts and bolts objectives. This is not my personal objective of today. That comes in hopefully the back 3/4 of this presentation, where we get everybody talking to each other. Okay. So I'm going to give you a little background on ESRD and hemodialysis. This is for the non-nephrologists in the audience, if there are any outside of healthcare that need a little refresher. Demographics of undocumented patients and undocumented ESRD patients. We'll talk a little bit about the legislation. As well as being a non-ethicist, I'm also a non-lawyer, so this is my thumbnail interpretation of this legislation. Funding, or the lack thereof, for the undocumented ESRD patient. We'll talk briefly about that. How the nephrology community feels about this whole issue. I've got a position statement that we'll kind of run through. And the ethical questions for discussion, and these are probably not the only ethical questions. These are the ones that I struggle with. I struggled with as a fellow and currently as a faculty. So, and this is where I'm going to call upon all of you to help us sort through these. Again, we're going to try to put some signposts in this ethical landscape. Okay? All right, ESRD, end-stage renal disease. As the name suggests, this is complete loss of kidney function. And in the United States, diabetes and hypertension, and any other country where we export Pizza Hut and KFC, they also have similar problems. So this is a big, big problem in this country. And if their kidneys aren't working, obviously they require a renal replacement therapy, which we call RRT. And several available hemodialysis And this is just a little cartoon picture of this. I'm going to try to use this pointer here for this. This is the blood dialysis where, to those that don't know, we take a patient's uremic blood, goes through this filter here, and then back into the patient, all clean, and the electrolytes are corrected, etc. It is the most common renal replacement therapy in the U.S. And we typically do this. The standard of care for dialysis in this country is 3 times a week. Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, typically for 4 hours at a stretch. There are other options, though. There's variations of this. There's daily dialysis, and there's nocturnal dialysis. I'm not going to spend a lot of time on those. There's peritoneal dialysis, and this peritoneal dialysis takes advantage of our body's own little hemodialysis filter, which is this peritoneal membrane here. And the way this works is patients infuse clean fluid, and then after several hours of dwelling, all the toxins move out of the blood via the peritoneal membrane, blood vessels into the fluid, and then that fluid is drained down here. And there's a lot of different flavors of this, but that's basically peritoneal dialysis in a nutshell there. And then kidney transplant. This is the best, probably always will be, but as far as a renal replacement therapy option, but as you all probably well know, there's finite organs, limited supply, etc. But again, this is another option, the one we would love for all of our patients to have. Demographics. About the undocumented patient, the name suggests they're undocumented, so as you would suspect, it's not collected systematically and is limited. So we're always dealing with some estimates. But it is estimated about 11.7 million undocumented immigrants are living in the U.S. This is 2012 data. It certainly has a growing patient population, or a growing population, 3.5 million in 1990. So it's really increased from the 90s. The majority are Hispanic, Mexico, Central America. And another estimation here, but we think there's about 5,500 undocumented immigrants living in the U.S. with ESRD, or end-stage renal disease. Not all those patients are receiving a renal replacement therapy, but they would meet the criteria by their estimated GFR, which is kind of an overall measure of their kidney function, of being ESRD. Now, these are the legislations, and I'm going to run through this as well. But it all started, I'll start up here in 1972 during the Nixon era here. And this is when Medicare started paying for renal replacement therapy for U.S. citizens. Okay, they came to the correct conclusion that no one could afford hemodialysis. It's far too expensive. So even if you're below the age of 62 or 65 or 67, I'm not sure what it is at this point, you could still have your dialysis paid for by the Medicare program. Very, very important program. And then 14 years later, we came up with the Consolidated Omnibus Budget Reconciliation Act, COBRA, also is known as Very High Insurance Payments. But anyway, this was probably the first one that had a tremendous impact on our undocumented patients. It prohibited federal Medicaid participation for undocumented immigrants except for emergency care. But it did establish EMTALA, so this was a good thing. And this was the Emergency Medical Treatment and Active Labor Act. And what this act, again, I'm paraphrasing a bit here, it allowed patients to be treated in the ER for an emergency condition, regardless of their documentation status, regardless of whether they had insurance or not. They had to be treated in the ER. Fast forward 10 years later, we have PERWARA, which is the Personal Responsibility and Work Opportunity Reconciliation Act. Love those words there. This, again, another impact on undocumented patients, explicitly denied all state and local public health benefits to undocumented immigrants. This law did give states some latitude, and we'll see the impact and the ramifications of that, because it did force states to pass laws specific to their own state regarding coverage, how much they would cover, who they would cover, etc. And then 96, we have the Illegal Immigration Reform and Immigrant Responsibility Act, otherwise known as the Immigration Act. And this required the minimum level of documentation for immigrants to receive health care. Okay, so in order to receive health care, they have to be documented, which obviously would leave out your undocumented patient. From a financial standpoint, there were a couple laws in 97 and 2003 that provided money to hospitals that serve a large undocumented immigrant patient population. Those were finite programs. The Balanced Budget Act expired in 2001, and then this Medicare Prescription Drug Improvement and Modernization Act expired in 2008. But it did recognize that there is a tremendous economic burden for these hospitals, and they did provide some extra money. We'll talk a little bit more about that later. So what do these laws mean for an undocumented immigrant with end-stage renal disease? EMTALA, as I mentioned, mandated that all hospitals receiving Medicare funds, which is pretty much all hospitals, have to evaluate all patients coming to the ER for an emergency medical condition. And they receive this medical care regardless of the immigration status. And the goal there is to treat or stabilize an emergency medical condition. And this includes hemodialysis. So emergent hemodialysis must be provided to undocumented immigrants with life-threatening complications of kidney failure. And just as a sidebar or important point, there are no federal funds to provide for outpatient maintenance hemodialysis therapy for undocumented patients. Okay, there's no federal funding for the 3 times a week standard of care HD for patients with ESRD, for the undocumented patients. So what is this emergency medical condition? The federal definition is broad, probably by design, I imagine. It's hard to codify all those possible clinical scenarios that can arise. But to paraphrase here, it's the absence of immediate medical attention could place the patient's health in serious jeopardy, cause serious impairment to bodily functions, cause serious dysfunction of any bodily organ or part. What this broad definition allowed is it permitted some states some flexibility. They could determine what they thought an emergency medical condition was and whether it would be covered by Medicaid or not. Also explains to a certain extent there's some disparity in the coverage for hemodialysis among the states. And this is a moving target, so I'm going to give you some states that do provide outpatient hemodialysis. But again, this is a very active, politically loaded and moving target. So again, some patients are providing 3 times a week dialysis for undocumented patients with ESRD. The ones that have done it consistently for the most years are probably California, New York, North Carolina. Georgia provided outpatient hemodialysis in 2006, then again in 2009, and in 2011 they had 20 or so undocumented patients were provided with 3 years of outpatient hemodialysis after an agreement with Grady and Fresenius. Fresenius are a big corporate hemodialysis company, and if you're checking your watches, 3 years plus 2011 makes us 2014. Unclear on the current status of this cohort, but I do know that clock has run out, so I'm not sure exactly where they're at right now, if they've made another agreement or if they're just providing emergent dialysis only. Houston, Texas, interesting little city, big city, of course. The Riverside Dialysis Clinic in Houston, Texas provides outpatient hemodialysis to undocumented patients. They're one of the border states, so this is a very big issue for them, and they've been able to carve out some money for that. And then Arizona, you can add that to those other 3 there. They attempted to discontinue it in 2002. There was a typical litigation. They relented and now are providing outpatient hemodialysis again, at least last time I've looked, which was recently. So current models of care. For U.S. citizens, permanent residents with ESRD, hemodialysis, as I mentioned, is provided 3 times a week. And this is the quote, the outpatient maintenance hemodialysis. U.S. citizens and permanent residents also receive specific medical therapy for the complications of ESRD. It's not all about removing toxins in these patients. These patients also suffer from high blood pressure, both that causes the ESRD and as a result of the ESRD. They also have anemia, the CKD, the chronic kidney disease associated anemia, and they have mineral bone disease due to some perturbations in the calcium and phosphorus balance there with ESRD. For most undocumented ESRD patients in the U.S., with the exception of those states I mentioned, hemodialysis is only provided on an emergent basis as needed. We call this PRN dialysis as the nomer there. So what typically happens in these scenarios, again, this is for most hospitals in the country, an undocumented Esrd patient will present to the emergency room. The physician will evaluate the patient, make sure they don't have one of those life-threatening medical conditions such as hyperkalemia, which is potassium is too high, or they're fluid overloaded. Because again, not only are the electrolytes, not only are we correcting electrolytes in these patients with hemodialysis, we're also taking off the fluid they accumulate. And fluid overload can manifest as pulmonary edema, which is fluid in the lungs, so they can't breathe well. They can have severe hypertension, or they can have this uremia. Uremia is kind of this umbrella term for a constellation of symptoms that includes confusion, nausea and vomiting. They can have arrhythmias and seizures, other cardiac abnormalities. So again, if we see, if the physician sees any of these kind of findings, then they are in need of dialysis on an emergent basis. Again, any lever present, patient goes in, gets his 4-hour run, sometimes kept the next day, dialyzed again. But if not, patient is discharged, instructed to return to the emergency room, typically the following day for another evaluation, or if they start feeling ill. Okay. And that's the typical approach for most hospitals in this country. Funding, all right, as I said, the lack thereof. The General Accounting Office outlines 3 funding sources. Some of these are just of historical note, but I put those in here anyway. Medicaid, and this is for emergency medical services only for this patient population. There's this disproportionate share hospital DSH payments, which are similar to those 2 acts I mentioned earlier. These are supplemental payments to certain hospitals serving large numbers of low-income undocumented immigrants. I'm a little vague on the details of how much money this typically is, but I do know that these have been reduced to the Affordable Care Act. Now, whether that's made up with other areas, all I do know is that they've certainly been reduced here. And again, this is the ones I mentioned earlier. Those were finite programs, needed but finite. And again, same focus there, providing money to states serving large numbers of undocumented immigrants. So within Medicaid, we have emergency Medicaid. And again, a few states, their definition and what they can use emergency Medicaid does include outpatient maintenance dialysis therapy. And those were those 4 states I mentioned. But I can tell you the Affordable Care Act, there's no little codicils for anyone that's undocumented within the Affordable Care Act. So they are excluded from all the programs of that. All right. So where does the nephrology community stand on this? This is the Renal Physicians Association, one of the larger organizations within nephrology. In 2009, they came out with a list of 5 statements here. These are not really very pithy to me. They're a little lukewarm, but and a lot of the things they talk about are kind of standards of care anyway. Especially number 1, all healthcare professionals and healthcare systems have an ethical obligation to treat the sick. Of course they do. We all know that. The one that I guess I find a little funny is that nephrologists should not be expected to act as agents for the INS, which is reassuring to me that I don't have to play that role. But again, I'll give them credit for coming out with the statement. It is not as strong as what I'd like, of course, but there is where the nephrology community stands, at least within the Renal Physicians Association. All right, good. All right. Now, let's talk about some ethical questions. This is where everyone helps, everyone in the audience. Okay. And these were ethical questions that I've had, both as a fellow and as a faculty. These are not the only ones that are out there, certainly, but these are the ones that, again, that have troubled me the most. And we're going to try to, again, put some signposts in this ethical landscape or attempt to do so. All right. So the first one: are healthcare providers ethically obligated to provide the same standard of medical care for everyone? So let everybody think about that for a little bit. And if no one talks, I get a call on people, all right? And nobody wants that, okay?
In a perfect world, yes.
Okay. And you could get as granular with this as you would like. Anyone else want to argue against that or add something to that?
I believe when we look at the value of life and the dignity of humanity, everyone should be treated fairly, and people deserve proper treatment medically. But we live in a situation that we politicize and then, permit me to use this language, monetize even medicine. Thus, we make money out of medicine so much that at certain times we cannot provide what we actually in our heart would want to provide, because there are some other or external forces that come into our medical field, and we call them politicians, and they decide a lot of stuff for us. They are not here to experience what we experience, but I think the medical field has a language of a own, then has a voice of a own that can one day be able to speak out. We hear you, but here's what we can do. And everybody, insofar as they are human beings and they have the dignity, need this type of treatment.
So, Brian, I'm going to pull a Donald Rumsfeld on you and take issue with one of the premises inherent in your question. So I would probably reword the question and say, are healthcare providers ethically obligated to attempt to provide the same standard of medical care? And the answer to that question is clearly yes, because, I mean, inherent, one of the assumptions of it is that we actually have the capacity to make all of the provision, which we clearly don't, especially in this area, which requires actually very expensive, highly technical, and not perfectly widely available treatments. So I think our ethical obligations are certainly to attempt to provide, to advocate on behalf of the patients for whom we have fiduciary responsibility, and to do, in a sense, everything in our power to help the patients along the lines of Father's comments. But that we will not be able to provide all of those treatments in under any given set of circumstances. That's the perfect world problem, right? We don't live in that perfect world. Sure.
I think the response is yes. We might not always be able to, but the response still continues to be yes.
Anyone else want to weigh in on this? All right. Thank you. Is providing hemodialysis only on an emergent basis to our undocumented ESRD patients ethical?
It seems ethical, but it's very scattered as far as care goes, because the standard of care is 3 times a week, 4 hours, whatever. So when the patient presents to the ER and they're hyper or hypokalemic and you've got all the usual stuff going on, you've got a sicker person you've got to take care of. But then the other side of the coin, schedule them 3 times a week, nobody pays. So it's a dilemma that's just circular in motion that you can't fix.
I'm going to have to respectfully disagree with you and say that I absolutely find it completely unethical, and that we have to separate the monetary issue from the ethical issue in this case, and that if we're looking at this from an ethics standpoint, it's neither just nor equitable to only provide these human beings with care when they're so sick that they're on the verge of dying. I believe that when we're looking at it from a monetary situation, I don't know the facts and figures to see if it would actually save money to provide them dialysis. It's non-emergent. I don't know if you can speak to that.
Yeah, exactly. And I purposefully left cost off of this equation, okay? I've got the slides in stow. If we have some time, which we very well may, I've got three articles that we can discuss. And my purpose for that, for doing that, was to kind of pull the money out of it and really get at the core ethics behind this. We all know it's a truism. ESRD is expensive. It's a lifelong therapy for most of our patients, and it's very difficult to pay for, obviously, because of the expense. So those are kind of things I think we all understand, and I think we all have an appreciation that emergency care, despite the great doctors that work in the ER, as far as a substitute for having a primary care doctor, having a dialysis unit that you go to 3 times a week, that the patient's not going to do as well. But we can talk about those 3 cost slides here. But I wanted first to get at this ethical landscape for me, and this is an artificial environment, I realize, because we're not talking about that yet. So is it a perfect world? It is right now, okay? So
Absolutely
exactly.
Unethical.
Yeah.
So I'm going to go out on a limb and say I think it's unethical to give end-stage renal disease special disease status and make that the one disease that we cover for everybody in the United States, regardless of their documentation status. I think that it's unethical to not consider that it can be a terminal disease, and it requires, for best standard of care, it requires patient engagement in best outcomes, and we don't see that. So I think the whole thing's broken. So I guess I should have answered your first question. It took me a while to catch up. I guess I should have answered your first question by saying I don't think end-stage renal disease should have special disease status and be the one thing that we pay for.
I guess I would not have, I wasn't going to make as much of a forthright comment as much as ask the question of the group and actually to our speaker, sort of where, if we step back from sort of this set of questions about it, where do we, how do we understand sort of this designation of end-stage renal disease, and what would, in your opinion or others, make it different from any other kind of sort of life-threatening illness for which people every day don't have access to get care, people documented and undocumented. So I think it's an interesting situation that has been set up because of an interesting set of policies that have been put in place. But there is sort of this conversation happens in a context where people every single day do not have access to the care that they need, and so that's just sort of a larger question.
I actually kind of want to respond to that bigger point that people are making, which is to say that that I don't necessarily see how talking about dialysis for end-stage renal disease patients in this situation is any different from any other disease state where somebody needs emergent treatment. So rather than comparing the PRN dialysis in the ED to the standard of care of the 3 times a week, you would liken this to somebody's coming in acute cardiac arrest. They emergently need treatment in the same way between those 2 patients. And then I have a question though about, I guess it sort of plays into, I needed this answered in order to decide.
Sure.
Are we doing harm by giving them occasional treatment?
I think that it's like what you were saying back there. I mean, I think that this is possibly causing more harm because you're not doing the optimal treatment. You're not treating them at the standard of care, so you're causing them to go into a crisis before they receive treatment again, which can further damage, to the rest of their organs and further in-organ damage, therefore causing more harm to the patient, not to mention their psychologically or psychosocial situation in causing a very difficult quality of life for someone.
Yeah, and maybe I can talk a little about that a little bit. As far as causing more harm, the thing about dialysis and ESRD is that it is a life-saving therapy. So we're, to the extent that we're saving them from death, because there is no substitute therapy for those patients when they reach that kind of that crisis mode, when their potassium is too high, when they're uremic, when their acid levels are too high as well. That's a patient by patient question.
Just wanted to say, I think we need to be really careful about the words that we're using to frame the issues. So when we say, are we causing harm by offering, emergent dialysis, that's only in contrast to the alternative, which is either not to offer dialysis at all, or to instead be able to provide financially, medically, and otherwise, dialysis on an ongoing basis. So, I mean, the cause of the harm is not, the provision of the emergent dialysis, right? In that, so I just wanted to be clear that I think we should be clear about what the actual cause of the harm here is. The actual cause of the harm is that we're not, at least under our current system, fully financially, logistically, legally, and otherwise able to provide the much better, much safer, much more medically appropriate alternative.
I think there is a difference in some situations because, like, I work on the trauma floor, and we have undocumented immigrants that are in accidents, and not all the time, but there are a number of occasions if they have fractures or something like that, we could get them to the point with the emergent care where they can carry on with their lives, and even though with dialysis you can too, but the thing is with dialysis, it's an ongoing situation, and if you have people who are just coming in every time there's an emergency, really in the long run, I know you don't want to spend time talking about costs, but I think in the long run it is going to be more costly for the system because I think a number of these people are probably not going to come back in until they're at death's door. They end up in critical care, and you spend a fortune of money trying to get them stabilized versus if you would permit them to dialyze on a regular basis, I think you would definitely keep them more stable, and in the long run, I think it would be less cost to the system rather than waiting for get them stabilized with the hemodialysis. It's no longer considered emergent, but you're always going to have emergent. It's going to come back and come back and come back.
I don't want to muddy the waters. I've only worked in dialysis and transplant my career. If a patient came to IU Health and had cancer and needed a bone marrow transplant, stem cells, something like that, what do we do for those people? Can someone from the ethics world tell us, are those people treated, or because they don't have the funds, because they're illegal? What happens? Thank you.
In general, people who face those circumstances are, treated on an individual basis. So, some bone marrow transplants in certain conditions are highly successful. For example, the outcomes are highly successful, and on the basis of the justification inherent in those outcomes are offered transplant. There have been other cases that actually we've reviewed in the ethics consultation service where the outcomes of the bone marrow transplant were so sort of inherently poor in a way, or that the odds of success were so low that a different decision was made. And the lack of authorized status of the patient was a factor in that decision, but not the only factor, if you see what I mean. I guess that's been my experience with
I have just a question and a response. My impression or understanding is that there was sort of a recent sea change around, I know, at least in the breast cancer arena, where patients who historically used to, I guess, the formerly Wishard Advantage used to cover like radiation, I would assume it'd be radiation therapy for patients, even if they had to come over to IU to get it, and then there was sort of a recent change. So, I bring this up not because I know the details of the policy, but I do appreciate that by virtue of documentation status, there are services in our healthcare system that people are not able to get at this point by virtue of their status. Because, essentially it was Eskenazi, or I guess formerly Richard, was like, well, we're not going to take on the cost, and then IU was like, well, we have a share that we'll do, but not everyone. And I think at the end of the day, a lot of these issues do come down to the distribution of resources. And the reason my original question that I raised my hand for was just to say that I think it's an interesting frame to present that, well, we want to talk about the ethics without talking about the money or sort of the resource allocation, because I mean, if we appreciate justice as a component of the ethical conversation, then I don't know how we would be able to leave that out or pretend that that does not factor into sort of our ethical consideration. And I don't mean justice necessarily as far as sort of sameness, which I appreciate as the first question, should everyone just be treated the same, but more to the point of sort of the distributive sort of justice component of how do we want to allocate scarce resources, amongst whom and for whom do we want to provide care. I think that's at the heart of what is sort of the ethical conversation that's going on here.
I guess I want to add to that I think it's impossible to have this conversation without talking about cost at some level, because the bottom line is that the reason this is a problem is because of money. And I wish we lived in an ideal world where everyone was covered. But the bottom line is it seems to be kind of a combination. The fact that Medicaid will pay for emergent dialysis but won't pay for routine 3 times a week dialysis seems to be part just because of the patchwork of legislation that's been passed about this. In part because maybe there's at least some perception, at least whoever's paying for 3 times a week dialysis just isn't going to take on the burden of dialyzing undocumented immigrants. And I mean, I think it's important to address the role that plays, because the bottom line is in the end it comes down to money. If we had all the money, we wouldn't be having this conversation.
Someone behind you?
I just want to raise another question here. If an undocumented patient were to have maybe an organization or a group of friends who want to pay for that service, would there be a change of game there?
That's a good question. I don't think I have the answer to that. Obviously some special arrangements would have to be made, but payer sources being important, I would probably say yes. Though, yeah. Go ahead.
Okay, I think we're all bringing up very, very good points of all of us on the front lines of medicine, that there are so many impactful things that happen with medical insurance and government policies and finances and illnesses. And what we see typically is that there is a disparaging gap in almost any type of illness on what issues are kind of a covered benefit, what isn't, how has our system set this up. And one thing that really comes to my mind is that what I see all the time is that when patients are seeking aggressive treatment approaches, sometimes knowing that the outcome is going to be the same as if they weren't seeking those aggressive things, but insurance pays for those things generally, and I'm not talking about the undocumented cases, but if they were here in the hospital with emergent Medicaid, it would pay. But if they stop those treatments and say, let me live the close of my life as dignified as I can, then suddenly those benefits are not there for people. And we play what's called the skilled care game every day in the hospital, trying to find a skilled care need for someone that would truly benefit the most from hospice and being in a loving, caring environment. And it's just very sad because it's us as people that have set up these rules and legislation, and the very people that we want to help, we're limited by what's available. So when it goes back to the ethical question, I think we have different answers, going back to what our nurse practitioner said at the beginning, that in a perfect world, but we know that there's all these other factors that come into it. And is it fair to ask people at the close of their life to say, I'm sorry, you don't have a symptom that needs to be managed in the hospital, so you're dying, but you need to leave the hospital. And I think those kinds of things aren't being answered in our current healthcare situation with insurance, or even those of us that could advocate more.
Thank you. I'd kind of like to add something. Many, many years ago, Ed Pellegrino came and asked a question that has just sort of been resonating with me since. So he's, for those of you who don't know, he's like the granddad or great-granddad of American bioethics, a wonderful clinician. But he said once, he said, when people tell you that there's not enough money to do something, he said, really question that. He said, we are a nation, this is in 1997, who spends $3 billion a year on potato chips. Now, aside from what that does to our kidneys and everything else, I think when I heard that, I thought, I mean, even I think it was billion, but even if I'm off by a factor of 10, it's still a whole lot of money on potato chips. And the idea is, in this community, what are we spending money on, which we could change? We could actually reallocate, we could redirect, and we could take care of a whole lot of people a lot better than we're doing. I think I'll speak for myself. I was very, in a sense, disappointed that the ACA did not go far enough, I think. I mean, my personal feeling, we could have gotten, I think, a lot more people covered with better basic coverage in a more just and equitable way. But we should not stop and just say there's not enough money. I really think we should question that and say, where is the money and how can we think about priorities? And one of the ways I think we change it is by having conversation like this. Thank you, Brian, for getting us started. But I mean, I think we need policy, we need the institution leaders, we need community leaders, we need help. Speaking as the outgoing chair of the Esrd Ethics Committee.
Anybody else want to add anything to that? Yes.
I wanted to agree with everything Dr. Gaffney said. We spend more money on healthcare than any country in the world. In fact, we spend more money than many other first world countries combined, yet still have lower life expectancies, worse chronic diseases, and worse, we die more unhealthy. We live more unhealthy lives and we die sooner. Yet we have the conversation where we say we don't have the money. And that just strikes me as odd that other countries have managed to be able to provide hemodialysis to all of their patients, including their undocumented immigrants, and yet we're still struggling that in this country.
Paying for hemodialysis?
Yeah, mostly through emergency Medicaid, I believe. Not entirely sure on that, but they've been able to, unless someone else has more insight into that. Yeah, again, there we go.
As we all know, that Medicaid is by state. So each state makes their own funds to cover. So those states, yes, they do. So my question is, what are we doing as a community, as a state, to get the legislation to change this Medicaid emergency? Are the leaders from the hospitals or as medical providers, what are we doing to correct this so we can do like other states do?
And I just wanted to add to this string of comments, which is very important. Then I'll let any hospital leaders in the room say something. But I mean, the two largest dialysis companies in the country, both of which are for-profit, have been, and I'll be pejorative on purpose, feeding at the trough of Medicare around dialysis for many, many years and have profited enormously over the course of the last few decades. And the fact that, so the Emory solution actually I think is genius, although incredibly hard won, because it actually said we need to ask them to pay at least a share of this and to participate in this problem because they have profited enormously for decades. So there's some of the money that's sloshing around the system that isn't being used.
I can. Some of the other countries, and whoever brought up that answer, thank you. Peritoneal dialysis is very common in other countries. Obviously, less so here, and that's a home-based therapy. I'm not sure the price differential is, but it is a home-based therapy. So I do believe there's a lot of PD going on in other countries, certainly Mexico. Yes.
That's one thing I was going to ask about this is PD. I do know that's where the federal government is pushing us to go, and that is where the more funding is available, and it is less expensive for the healthcare system to run PD. In Europe, 86% of all patients are ran PD, and so that is one area that I think we should look at to cut our costs down the road.
It is as though it's obvious that the policy we have is kind of controlling everything. So perhaps it may be good if all the hospitals will come together and see how they can influence and change the policy of Indiana State, particularly, when it comes to ESRD, so as to have a more humane way to approach this huge problem, that could be very helpful in saving lives of people, that are here, irrespective of whether they have any kind of paper or not. Because, our goal has to be to help in saving life and in making people a bit healthier, than they have been before.
Anybody else on that? With finite financial resources, what obligation do healthcare providers have to maintain the financial viability of a hospital that provides healthcare for the underserved? What is our responsibility as clinicians? Or do we have one? Do we just, hey, do what we need to do? Let's just think about that for a bit.
Well, again, I think the government has to step in here. There is need for the government to really think about, again, its policies so as to help those who are in the medical field. Everything, is being determined by the government, so to say, to a large extent, because they make the laws. So if the laws made are not favorable in any way, so we're going to have difficulties in having a strong financial status. There is no way a hospital can survive without having a good financial background to run its services. So that is the first thing. So the government, on one hand, has to do its job, and then those within the realm of medical care has to play their own role too. But however, there should be a way that these things are kind of controlled, whereby there are checks and balances put in place to make sure that abuses don't come in at all. See, because when we don't have these things in place, and then anybody does anything, we shall end up having a very difficult financial stand for any medical care.
I think we can use appropriately the limited resources we have. We should collaborate with community organizations. We should engage in the community. We should educate the community and volunteer. There are so many free clinics in town that limit the flow of patients to our emergency departments. And I think that's a way that we all could be preventing the inappropriate use of medical resources.
I think in particular to end-stage renal disease, we need to also be looking at resources that help prevent getting to this stage of disease with patients. So treating diabetes better, treating hypertension better, having more education and putting resources into that to help prevent to get to this point.
I want to add something to that, which is, I mean, I think this is an incredibly important point, which is, and I think it's been raised with the folks who have questioned why end-stage renal disease is kind of treated as a special disease. And I think, again, that's kind of an accident of history because Medicare agreeing to cover it. But from the hospital's point of view, I mean, our hospitals have a population, and this is growing more and more common. I think it's always been the case for our public hospitals, have a population of people that they have to care for comprehensively. And they have to make tough decisions all the time. I mean, I know as someone, I've practiced at Grady and I practiced at Wishart Eskenazi, and I know that we're always making choices about where the resources are going to go and what disease is going to get treatment. And so I think it is important when we're considering end-stage renal disease to consider good stewardship of the hospital. I mean, that has to be a value. And I guess I would add to that, and maybe you could elaborate on this from a fact point of view, is that you can't really understand the situation without thinking about where the money's flowing. And my understanding is now when these folks come to the emergency room, they are dialyzed and the hospital is reimbursed by Medicaid. And so I think it's important to know that as far as I know, at least at this point in time, the hospitals are paid for that emergent dialysis. The problem is what would happen if they did a dialysis that wasn't judged to be emergent. And the question is whether you kind of, just scurry the person along to dialysis and say it's emergent when maybe it doesn't quite meet emergent criteria, or whether you're really strict about saying we're only going to dialyze people when they come in with, I don't know what, a potassium above X or uremia above a certain level. I wondered if you could address a little bit that question of where the money's actually flowing, because I think it really relates to the stewardship question.
Yeah, and it probably would be predominantly emergency Medicaid, and Dr. Weaver, you may be able to provide some more insight into that, being on the front lines of this, perhaps, if you'd care to.
Sure. You are accurate that if they come in and meet emergency criteria, then there is funding through emergency Medicaid. Now, it doesn't come close to making you whole, but those of you know that I work at Eskenazi Health, and I guess we're pretty used to not being made whole. So, we make that, we do okay. We make that work. The question comes into exactly what you voiced perfectly, Lexi, is to get any funds from Medicare, Medicaid, across the board for any patient that we take care of, we have to follow the rules of CMS and Medicaid, et cetera. And if you are funneling patients through or doing things with patients that don't follow those rules, then you put yourself and all of those patients that you're caring for at risk to lose any and all funding for any of those patients, which, then you end up with 1.5 million patients that you can't care for instead of however many that you can't care for the way you would like to. It's hard, and it gets back to the ethics part of it. I think it's really always hard to differentiate the definition of ethics from compassion, but I don't think they're the same thing. I think we all, if we could do anything in the world we wanted to do, would do many, many, many things in healthcare very differently. So we're wrestling with this, and thank you all for having this conversation. I can add later, we are having this in other circles and things, and it is very important to us. But as expected with this crowd and Dr. Decker and everybody else involved, this is excellent, and thank you all. So I'll be quiet and listen most of the time.
Anybody else want to weigh in on this? Is emergent hemodialysis? Yeah, go ahead. Someone else? Yeah, go ahead.
Though I missed some parts of this, but I'm here to know about the documentations in terms of, I had someone talk about free clinics now, and are we sure that the records between the free clinics and those in the regular clinics are aligned if we are trying to continue care for these patients that are having problems with the renal diseases and related?
Yeah, sorry, maybe the mic. I just caught like the back half of that question. What was your question specifically?
It's about the continuity of care documentation in terms of Some people going to free clinics and those going to regular hospitals. Are we sure that the records are aligned for continuity of care?
Yeah, that's I would hope so. I have no way of knowing for sure. I mean, certainly that's part of being a good clinician, but I have no way to confirm that. But I certainly hope so. All right. So, got about 5 minutes left. Is emergent hemodialysis for undocumented ESRD patients a form of healthcare rationing? Healthcare rationing was a big topic when the Affordable Care Act was coming online. Kind of faded in the lay press, but this is the question that I had. Is this healthcare rationing in some form? Yeah, question right down.
I think healthcare ration is geared towards saving money, but emergent ESRD would rather, take more money from the healthcare cost. So I think it is really a contradictory, way of, thinking, so to say.
Okay. Anybody else have an opinion?
Sorry, this may just be restating what you just said, but just to be clear, if it is, then it's a really inefficient form of rationing. Because if you have a financial goal, an economic goal of rationing, if that's the idea, if that's the motivation, then probably not so good. If you're doing so, if your definition of rationing is intended, and I don't mean yours personally, if sure. One's definition of, I'm not attacking you, if one's definition of rationing is perhaps giving to each as he's due non-economically, so what is the value of that person and what will we give to that person because of his value? I'm not saying I agree with that at all, but if that's the definition of rationing, then yes.
Anyone else have a thought on this? All right. Is less, oh, yes. You okay? All right. Is less than the standard of care for a specific therapy healthcare rationing? As we understand healthcare rationing. No thoughts on that? All right.
I think this other question here presents an ethical problem because you cannot think about standard of care and then for a specific therapy, healthcare rationing. Why do you have to provide a care that is less than standard? That's the first question. Then why are we into medicine then, if you have to provide a care that is not standardized?
Okay.
I guess the thought that, of course I've lost it now. I'll find you later.
Yeah. Okay.
I'm going to add a comment, which is something about rationing suggests that it might be rational. And I think in this case, it's based on one thing, which is ability to pay through access to insurance. Mm-hmm. So there's no rational decision that suggests that an undocumented immigrant has less of a medical. It's not based at all on medical criteria. It's merely based on access to insurance. That's the sole thing that we're basing these decisions on, okay. Kind of de facto.
To insurance, because that was the point that I lost, was that I think what's interesting about this is that if this is sort of like our government or sort of an attempt at healthcare rationing, because of all the reasons that people have said, I think even if you took compelling financial information to those folks. It would not necessarily move them, which actually makes me think that it's not as much about healthcare rationing, even if you want to put that label on it, as it is about politics, as it is about worth, as it is about immigration and how people feel about undocumented folks being here and having access to things that, citizens deserve, et cetera. So I think that it is interesting that this, so on the physician level, I would agree with what you were saying. Let's see about, it's more about the issue of access and insurance, but at sort of the meta level about what drives this larger discussion, I think it actually is probably less about access in that regard, because I think that even a rational argument about cost would not move the needle on some of the decisions that were made, particularly with the ACA and things like that.
All right, we're about out of time here, but and this is probably the big question for all of us today, and I don't expect anyone to solve this one or even have an answer for me. And it is the big question. Where do we draw the line on how much health care to provide? Because that is the fundamental question, I think. Ethical, financial issues involved in that.
As a palliative care doc, I have a hard time with that question because I think we have this assumption that we're going to stop caring for the patient. And so I think we can do a phenomenal job of continuing to provide compassionate, loving care to everybody under financial restraints of the system. So, to me, this is the aggressive care conversation, and I think we're limiting ourselves when we don't step away from that and look at a broader aspect of this.
All right. Any other questions or comments? Well, that's all I have today. Thank you we got one down here? Yes.
Kind of going with what he was saying, back to the resources question that you mentioned, how we can use resources to provide more care and palliative care in P. So the same thing, really having goals of care discussions and really talking to patients about what their options are, not just saying or assuming that because they have end-stage renal disease or whatever the condition might be that they want aggressive care. Really talking to them about what their options could be for care, not just dialysis, and knowing what they really want and giving them that education can really expand their resources for their quality of life and even quantity of life at times.
Brian, thank you so much. I'm afraid we're after 1 o'clock, so we're going to have to close, but I want everyone to give a round of applause for Brian for bringing this up.